Thank you again for coming back, and thank you, Anna. That was great. Really, if you think of questions after any of these programs that you didn't get a chance to ask, catch us, dinner time, whenever. We're happy to answer anything. So we're going to talk a little bit about walking issues in multiple sclerosis. And some of the first couple of slides are going to be a little bit busy, but I'll give you what the take-home point of the first couple of slides is. Why are we talking about walking issues at all? Well, because walking issues are common in multiple sclerosis. This was a survey done by a group called NARCOMS, and what NARCOMS found when they surveyed a large number of people with MS is that only one little piece of the pie there, it's about a 15% slice of the pie, of people with MS said they had no walking issues whatsoever. So 85% of the pie said they had some walking issues, and they ranged from mild to not walking at all, but the majority of people did have some walking issues with multiple sclerosis. So this is an even busier slide that you can't see that I'll explain to you that says what does walking do to a person's ability to work? And what they did is looked at both men and women with multiple sclerosis, and they found that unfortunately as walking got worse, the likelihood that the person was working full-time went down. So walking was strongly correlated with the ability to work full-time. It's interesting because when we talk about vocational issues in MS, the other two big things that affect a person's ability to walk are not as visible as walking issues, and those would be cognition and fatigue. We think that cognition and fatigue are actually the two things that are most likely to take someone out of the workforce, but walking is clearly up there as well. So walking, as when Anna talked about sort of this ripple effect of wellness, walking has that same sort of effect, where we think about one of those 6 facets of wellness affecting the big picture. Walking can have this ripple effect. So if you're not walking well, you may get deconditioned. You may become more socially isolated. You may become depressed. You start not going out quite as much, and it just starts cycling in a downwards way. Fortunately, we can reverse that cycle. We can stop that ripple effect by addressing walking issues for people with MS. So I like to think of walking issues in MS as being this sort of witch's brew of different ingredients. And we're going to talk about the 5 major ingredients that you may have. Some people with MS have all of these. Other people mainly have one of these that's affecting their walking, but we need to be aware of all of them. And those are spasticity, foot drop, nerve fiber fatigue, sensory ataxia, and cerebellar dysfunction. And we're going to spend some time talking about all of these and talking about what we can do to push back on that. Spasticity comes from a Greek term, spastikos, which means to draw or to tug. And so spasticity is this sort of increase in muscle tone. All humans have a balance between what our flexor muscles want a joint to do and what our extensor muscles want that joint to do. And so there's normally this balance. Multiple sclerosis or any health condition that affects the central nervous system, your brain or spinal cord, can throw that balance off. And so now, if you disconnect, if you will, the brain from the spinal cord with an MS lesion or a spinal cord injury or a stroke, you're sort of upsetting that balance and you're letting the spinal cord do more of what it wants to do. So what does the spinal cord want our muscles to do? Think about someone who's had a stroke. What do they look like in terms of their walking? Typically they have one arm, they have the arm drawn up and the leg is stiffened out. That's what the spinal cord wants the muscles to do. It wants your legs to extend and it wants your arms to flex. So that's what spasticity typically looks like in multiple sclerosis. Spasticity is sort of that chronic state of muscle tightness. On top of spasticity, you can have spasms. So this is that wave of sudden muscle tightness. So it can be a flexor spasm in the arm. It can be a spasm that affects your whole body so that you're sort of stiffened out. We see a lot of people that have extensor spasms in their legs when they try to transfer. So the legs will stiffen out on them maybe when they're going from scooter to chair or going from chair to sitting up. Most people with spasticity have really brisk deep tendon reflexes. When you see your healthcare provider and they tap on your knee and your knee jerks, we grade those reflexes from 0 to 4. 0 means we tap on your knee and you don't move at all. 1 means it's a little bit there. Most people live at a 2. That's a normal human deep tendon reflex. If we tap on your knee and it really goes out aggressively, that's a 3 or a 4. 4 is clonus. It means it's just the joint is bouncing. Some of you probably notice if you get your leg in just the right position or wrong position, that your leg starts bouncing up and down. That's clonus. That's a deep tendon reflex that's firing over and over again. So that's an exaggerated reflex. With medical students, if we like them, we warn them that most of our folks with MS have what we call get back reflexes. That means that you tap on their knee and you better get back. If they're a smart alecky know-it-all medical student, we don't warn them about the get back reflexes. So we talked about some of the signs of spasticity, the brisk deep tendon reflexes, spasms. Clonus, again, is that bouncy reflex. Spasms can be painful. Frequently they're painful for people. And so all of these things add up to impair your ability to function. That's really what it's all about, is your ability to do what you want to do. And spasticity can clearly affect your ability to function on a daily basis. So we talk about spasticity as if it would always be a bad thing, and Ian may cover some of this in the more hands-on talk about walking issues, but spasticity is not always bad. Let's imagine that you've got weakness in your legs, but you also have a little bit of extensor spasticity. Your legs want to stiffen out. Maybe you use that extensor tone to help with transfers or with walking. So one of the things that I like to do early on in people with MS is get them to someone like Ian or Anna, the physical therapist, to say, how much of the spasticity is bad and how much of it is good? How aggressive should we be in managing this? Because we always, on our end, we always have more drugs we can throw at you. And sometimes we don't want to go to that toolbox right off the bat. We would rather do things that don't involve more medications. So when we think about managing spasticity, we talk about a step-ladder approach. We want to address the easiest things first. And one of the easiest things to do, and one of the most important things to do, is to remove noxious stimuli. We'll talk about some of what is a noxious stimulus. Spasticity and spasms tend to be very responsive to what's going on in your life. If something's not right, you're overheated, you have a urinary tract infection, you're stressed, you're sleep deprived, these things can set off spasticity. And we want to try to address those, and if we can remove some of those things, use that as our first line of treatment. Next line of treatment is rehabilitation therapy, getting you in with a physical therapy, making sure that you've got a good range of motion or stretching program. Then we bring out the medications, and then sort of at the top would be something like intrathecal baclofen, which we'll talk a little bit more about. So these are some of those noxious stimuli, things that may irritate. Even something like a shoe or a sock that's irritating to you can make your muscle tone more. If you have skin breakdown, that's going to increase spasticity. I would say in our clinic, the most common thing that we see, if someone calls in and says, you know, my spasms have just really kicked up horribly in the past 24 hours, the thing that I'm always on the lookout for is a urinary tract infection. For many people with MS, their symptoms of a bladder infection aren't going to be urological, they're going to be neurological. They're going to be increases in your spasticity, more weakness, maybe more fatigue. So anytime you're thrown off your game, always kind of step back and look at bladder function. So rehabilitation therapy, stretching, weight bearing, Botox injections. If you have just a limited area of increased muscle tone, maybe we can have someone do a Botox injection. We don't want to do Botox injections into muscles that you need for function, because what Botox is doing is temporarily paralyzing that muscle. So we don't want to sacrifice muscles even for a short period of time that you need to function on a daily basis. Serial casting. What if you've got a contracture? You've had spasticity on an arm or a leg for so long that the joints are actually tight now. Well, that's going to be a tough thing to work with in terms of medications or just stretching. So sometimes what we'll do is have the person get serial casting. Put on a cast that's just going to stretch that joint a little bit, leave it on for a short period of time, do another cast, and just slowly over weeks move that joint so that it has better range of motion. And then we get to medications. So our two old standby medications would probably be baclofen on the top, and then the fourth one, tizanidine. These are our old go-to medications. Benzodiazepines, these are your Valium, Ativan type drugs, can be very effective for managing spasms and spasticity, but we have to also be aware they can be sedating and they also have some addiction potential. So not always our first thing that we would reach for. How many of you are familiar with the third drug on there, dantrolene or Dantrium? So dantrolene's interesting. It's, if you went to our spinal cord injury side of Shepherd Center, they use dantrolene all the time to treat spasticity. We hardly ever use it. Most people with MS have never heard of it. For some reasons I can't explain, it doesn't seem to work very well in our populations. It really works okay in people with spinal cord trauma, but I've just never seen it do much for a person with MS. But it is in the toolbox. Keppra or levetiracetam is a seizure medicine that we sometimes use to treat spasms. And then cannabinoids is actually misspelled. That second I should be an A. Cannabinoids we're going to talk about in my second lecture. So these are your quote-unquote medical marijuana, and this is something that we do look at for managing spasms and spasticity. Right now, the only real FDA-approved version we have is the Marinol or Dronabinol. Dronabinol is FDA approved for nausea in chemotherapy patients. It's approved in people with HIV to stimulate their appetite. It is synthetic THC, so we can use it sometimes to treat spasticity, but we'll talk about some of the other options on there in great length in the next lecture. So what if all of these things have been tried and just aren't working out? What if we could put the baclofen into the spinal fluid itself? So this is intrathecal baclofen pumps. So when we take baclofen by mouth, it goes into our GI tract, it goes into the bloodstream, it goes through the liver, a fair amount of it gets metabolized through the liver, and then some of it actually goes into the brain itself. That's not where we want baclofen working. We want baclofen working at the spinal cord level. Baclofen in the brain is where you get your drowsiness from. Baclofen at the spinal cord level is where you get your good anti-spasticity effect from the drug. So what if we could just bathe the spinal cord through the spinal fluid in concentrated liquid baclofen? In theory, you would get all the good without any of the bad. It is a surgical procedure. It's not something that we go to as a first option. This pump here that you see in the picture is about the size of a hockey puck, and it's just inserted surgically under the skin on your side, and then has tubing that runs under the skin and delivers that concentrated liquid baclofen into the spinal fluid. So shifting to our next one. So that was the first form of first thing that can affect walking in people with MS is spasticity. The next one is foot drop. This is actually one of my favorite things to talk about because surprisingly, you would think it would be pretty obvious that when people have a foot drop, but sometimes it's under-recognized and it's under-treated by the medical community. So if you had to pick the two weakest muscles in the legs in a person with MS, it's going to be your ankle dorsiflexors, your ability to get your toes up off the ground, and it's going to be your hip flexors, your ability to bring your knee up off the ground. So if a person only had weakness in their ankle dorsiflexors, they would do something called a steppage gait. They would bring their knee up higher so that their toes don't drag the ground. And if you go to most inner cities and you drive downtown, you'll see someone doing a steppage gait. These are sometimes people that have alcohol issues and they've damaged their perineal nerve on the outside of their knee. So they're walking with this very high step gait so that they don't drag their toes. The problem for people with MS is if your ankle dorsiflexors are weak, your ability to get your toes up, there's a good chance that your hip flexors are weak. So most people with MS cannot do a steppage gait. What they do instead is something called circumduction. They swing the leg out and around so they don't drag their toes. And this is where the significant others, the care partners for the person with MS are a great help. We'll say, you know, when you're watching your spouse, your brother, your sister, your mom, your dad, when you watch them walk, when they get tired, what do they look like? And they'll say, well, you know, it's weird. They go from this kind of to and fro motion to kind of swinging that leg out and about a little bit. So it can be subtle, but it is there. What's the problem with circumduction? Well, now you're using muscles to walk that you weren't designed to use to walk with. So it puts stress on your knee and your hip and your lower back, and it fatigues you very quickly. So you go from being a little tired with your walking to really hitting the wall and not being able to walk well. Traditionally, if we send you to a physical therapist with this sort of problem, they're going to prescribe an ankle-foot orthotic. And some people don't like their ankle-foot orthotics. There are great ones out there. I will say a lot of ankle-foot orthotics sit in the closet. We know for a fact, so we're on to you guys. You wear your ankle-foot orthotics when you come to see us, and otherwise they sit in your closet. You're just trying to make us happy. Don't try to make us happy. Do what's right for yourself. And so while the ankle-foot orthotics can be great for some people, there are other devices out there. So these are some of the lighter weight sort of variations of ankle-foot orthotics called toe-off devices. There are actually two over-the-counter devices that I'm going to talk just briefly about. There's something called the Dorsi-Strap. So if you just have a little bit of ankle of weakness, a little bit of foot drop, and maybe it only acts up when you really walk a long ways, maybe something as simple as this Dorsi-Strap device would do the trick for you. Maybe you have a trip to Disney World planned and you know if you walk a long ways, that foot's going to drag a little bit. This is a simple $49 device. It goes behind your heel and it laces up into your shoe. It doesn't give you any lateral support, but it will help you get your toes up off the ground. Very inexpensive, very comfortable. Kind of another over-the-counter device that's a little more sturdy is this device from a company called Saebo. The Saebo device is a pretty sturdy collar that goes around your ankle, and it has those little cables that come out and clip onto your shoe. You'll notice on the front of the device there's a little knob that's a tension adjuster, so you can crank that device in as much as you want. These things are sturdy. They're about $149, but it will last you forever. It gives you a little bit more lateral support. It will get your foot up off the ground. One of the things that we hear from individuals when they think about the ankle-foot orthotic, one of the reasons that people don't like to wear them is because they don't want people to see it. And so I would say these two devices are a little less obvious and can be easily worn under clothing. So then we get into what we would call functional electrical stimulation. What if instead of bracing your leg, what if we could in effect rewire your leg and make the nerve work again? If you can't get the signal from your brain to the foot to make your foot come up, what if we could just bypass the brain through a device? And so there are two that we think of commonly. There's the WalkAide device. This is a knee brace that goes around your knee. You can see the person has one on in the picture, the cartoon. And it's going to stimulate the peroneal nerve and make your foot come up. So what don't we like about the WalkAide device? The problem with the WalkAide device for people with multiple sclerosis is that it fires your foot, it makes your foot work again based upon acceleration and tilt. The device has an accelerometer and a tiltometer built into it. And the physical therapists have to set those parameters at a certain level. They have to say, well, based upon what I'm seeing here in the clinic, I'm going to have that device fire when you do X. The problem for people with MS is you don't do X all throughout the day. In the morning you do X, at lunchtime you do Y, and then late afternoon you do Z. And so people with MS have progression of symptoms sometimes throughout the day as they get tireder, and the WalkAide isn't necessarily able to adapt to that. It's set for one parameter. It may be better suited for someone with a stroke or spinal cord injury where that level of weakness is fairly constant throughout the day. So this is the other device, the Bioness device, and there are two versions of this. This was our original version called the Bioness L300, and I don't know if you can see down on her right shoe, she's got a little clip. So you've got the nerve stimulator on her knee, and then down on her shoe, she has a radiotelemetry device. That radiotelemetry device is sensing when her foot has to fire. It's sending the signal back up to her knee and saying, okay, make the foot come up. She also has a cuff on top of her peroneal nerve stimulator that can make her knee flexors work. So she's hitting actually two of the muscles in the legs to make her foot work again. This is the new version, the Bioness L300, and what they've gotten rid of with the upgrade is there's no longer the radio telemetry device on your shoe. So now built into this, there's a 3D, and Ian, you may understand the technology better. It reads your environment, basically, and so it can adapt as your weakness changes throughout the day, but you don't have to have the foot sensor downstream. You could wear this with no shoes on. One of the most important things, that, in my opinion, with these devices is I think everyone with a foot drop probably should be given an opportunity to try one of these out. They work wonderfully for some people, but not for everybody. Sometimes the person has too much spasticity in their legs and the device just can't overcome that spasticity. Some people find the nerve stimulus just to be uncomfortable and they don't like how that feels throughout the day. But I think these can be great things for helping with foot drop. This was a little case study we did in an individual patient a few years ago. This was an individual who's walking with a walker, and she does her timed 10-meter walk without her Bioness device on. And it took her almost a minute and a half to go 10 meters without the Bioness unit on. She puts the Bioness unit on and she cuts that in half, more than in half. She's 40 seconds now. So she doubled her walking speed with one of these devices on. So they can make a big difference for individuals with MS. So nerve fiber fatigue, and this is going to tie into what some of you folks were talking about with your heat sensitivity. So the way that nerve fibers should work in your brain and spinal cord is on the top part of that slide. So that's a sort of a schematic showing nerve fibers that have myelin on them. And you'll notice they kind of look like little sausage links on end. The gap between the sausages is called a node of Ranvier. It's a naturally non-myelinated area. And normally what happens when you want to get electrical information from your brain to somewhere else in your body, or from somewhere in your body back to the brain, the electrical information jumps from gap to gap to gap. It's a very fast, very efficient way to get information up and down the central nervous system. It's called saltatory conduction. So now MS comes along and it messes up that really good system. MS is going to come along and strip that insulation away from that nerve fiber, and it's going to leave a naked gap where there's no insulation. That electrical information can't jump that gap now. So what it has to do is reconduct itself in little baby steps across that naked nerve fiber. It's plan B. It works. It doesn't work as well as the original equipment, and that naked nerve fiber will always potentially be the weak link in the electrical conduction chain. So while it may work if everything's perfect, you're sitting here in a nice cool room, it's early in the morning, you hopefully had a good night's sleep. If we took some of you out now and said, okay, let's go out and do 20 laps around the track and it's 90 degrees outside, well then that nerve fiber has something called conduction block. It just shuts down. One of the important things to know with conduction block, so if you exercise or get overheated and you have a symptom act up, it's an electrical phenomenon. You're not causing damage, you're not hurting anything. Once you cool off, rest, relax, you're going to recharge your battery and hopefully be good to go. That time that it takes to recharge your battery varies from person to person. And some people, they can recharge their battery in 30 minutes. And other people, they're going to have to get a good night's sleep and really cool off before that battery is recharged. So how do we treat that? Cooling options. So the cooling supplies that the MSFocus folks help people with can be just a lifesaver for helping you get out and not be a prisoner in your own home and having to stay right next to the air conditioner. We have some people that like doing sort of improvised cooling vests, if you will. How many of you are familiar with camelbacks? So camelback is basically a canteen, if you will, that was developed for the military. It's like a backpack, and it's got a bladder in the back, and they come in different sizes. You can do a 1 gallon or a 2 gallon. And what I have individuals do is just take the lid, it's got a little screw-in lid, take the lid off of that and just cram that thing full of ice. The opening's pretty big. Put ice in it, put your water in there. It's got a little straw that comes around the top and it clips onto the strap here. So you've got your built-in cooling, you've got your cooling unit basically over your back, and you get these on Amazon for 30, 40 bucks. They even have backpacks now that have camelbacks built into them, so you can have your backpack with the camelback already in it. But those can be a nice, inexpensive, improvised cooling vest. Keep drinking supercooled liquids throughout the day. So making things that have the consistency of like a slushy or a Slurpee will really help you drop your core body temperature and help you tolerate heat a little bit better. Doesn't have to be water. There are other things that have that consistency. Pina coladas, margaritas, just saying, you're on a cruise ship. Yeah. So the next one we're going to talk about is compounded 4-AP or 4-aminopyridine. How many familiar with 4-AP? Some people. So before we had dalfampridine or Empira, the FDA approved third option there, we had 4-aminopyridine. These molecules do exactly the same thing. These are both potassium channel modulators. When you think about that naked nerve fiber, the way nerve fibers conduct electrical information is through sodium, potassium, and calcium channels, and we can affect how nerve fibers work by modulating how those channels work. And so 4-aminopyridine is a molecule that was made in mom and pop pharmacies. It was compounded going back to the 1960s. So this stuff's been around forever. And we never thought of 4-aminopyridine as something that just helped walking. It can. We thought of 4-aminopyridine as something that helped with exertional or heat-related symptoms. So if you said that your vision got dim if you got overheated because you've had a prior optic neuritis, we would try out 4-aminopyridine to see if it would help with that. If you said that your legs got weaker with exertion or heat, we would try out 4-aminopyridine. Well, then sometime about 20 years ago, a pharmaceutical company, Accorda Pharmaceutical, said, that's a really cool molecule. We should try to patent that. And so they started doing studies and to see if they could get FDA approval for it. Well, they had to study something very specific. You can't just say, I'm going to help heat sensitivity and exertion. You had to pick something. So they picked walking. And so Empira got FDA approval as the walking drug back in 2010. What they showed in their studies is that about 40% of people on Empira walked faster while they were on it. Empira, again, is really the same molecule as 4-aminopyridine. Just here recently, Empira went generic, so there is a generic form out there. What's the downside with 4-aminopyridine or Empira? Probably the biggest downside is they don't work for everybody. They work, again, for about 40% of people, and you'll know in about 4 weeks if you're going to be in that good 40% group or you're in the group who just doesn't get anything from it. We will not use these drugs if there's any suspicion that you could be at risk for seizures. So there's a fine line between improving electrical conduction in the brain and helping and doing that a little bit too much and actually provoking seizures in the wrong person. Sensory ataxia. So ataxia means you walk like you've had a drink too many. Sensory means you do it because you can't feel where your feet are at. So what MS can do is it affects proprioception, your ability to sense position. So I don't know if any of you have seen the t-shirts. I know several of our folks we work with have them. The I'm not drunk, I have MS shirts. I've seen those for a while. I had a spouse come in the other day and they had the opposite shirt on. They said, I don't have MS, I'm drunk. You know, that's a brave man. So sensory ataxia, again, you literally walk like you've had a drink too many. And so what does that look like? People with sensory ataxia tend to walk with their feet further apart. You're less likely to fall if you have a wider base. So putting your feet further apart. They tend to use what we call improvised assistive devices. They use their spouse, somebody next to them. They use the walls. They know where the furniture is at. They may use service animals. They may have a big dog that they lean on. And then we have formal assistive devices, so canes and walkers. Unfortunately, people are at risk for falling when they have sensory ataxia. So if you can't feel where your feet are at and you're at risk for falling, what is your brain going to use as a backup so that hopefully you don't fall? Anybody want to take a guess? Your eyesight, so your vision primarily. So if you can see the horizon and say, okay, I'm tilting a little bit, I better not do that. That's a backup mechanism. What's the problem with that? Is people take that away from themselves and don't even think about it. If you're walking and you're trying to use the horizon, as soon as you look at the person next to you and start having a conversation, it's just like closing your eyes and trying to walk. Standing in the shower with your eyes closed to wash your hair. There's nothing soft to land on in the shower if you go down. Yep, you go backwards, and we see a lot of injuries. The other problem that we see is when people get up to go to the restroom in the middle of the night. They don't have a night light on, and so you always want to have some kind of lighting. A lot of people compensate at home. They know where the furniture's at. So they get up, it's poorly lit, but they know, okay, bed, dresser, doorknob, boom. What happens when you come on a cruise though? Now that everything's in a different place and you start to reach and bam. So just make sure you have lighting on at night so that you're not putting yourself at a disadvantage. So we're going to shift now to cerebellar dysfunction. So the cerebellum is the primitive back part of our brain that it doesn't control things like sensation and strength. It really controls how much we move. So if you have a cerebellar issue, you may still be able to move your arm out, but let's say you want to reach out and touch something. What happens with cerebellar dysfunction? Yeah, you're going to be all over the place. So we see individuals with cerebellar dysfunction who have normal strength and normal sensation, but they still have significant trouble walking because they're just all over the place. So you can have cerebellar dysfunction that affects your arms or legs. You can have cerebellar dysfunction that affects your trunk as well. So dysmetria or tremor is one of the symptoms that we see with cerebellar dysfunction. Ataxia, again, walking like you've had a drink too many. Cerebellar dysfunction can affect speech. So sometimes what we see in people with cerebellar dysfunction is that rather than having the normal highs and lows with speech, their speech has kind of either a flat tone or the highs and lows are in the wrong place. So I would say cerebellar dysfunction can be one of the tougher things for us to treat. We do get therapists involved fairly early on. Our medications are not great for cerebellar dysfunction. We try out a drug called primidone or mycilene. Primidone's an old seizure drug. It helps a little bit with tremor. The problem is it can be really, really sedating for a lot of people. Deep brain stimulation. So if you're having a hard time controlling how much you move in an arm or a leg, a neurosurgeon can tap into the deep part of the brain called the thalamus and actually try to override your tremor. This is an interesting surgery if you ever watch a video of it. It's a surgery that's done awake. So the person is completely awake during the surgery. They numb everything at the scalp so nothing hurts, but the reason they want to do it while you're awake is they want to know when they've got the electrode in the right place. So if you were trying to give someone better function in their right arm, you're going to do the left side of their brain, and you're going to have them doing things with the right arm, trying to use the extremity and showing that when you've got that electrode just in the right place, that their tremor stops. We have a couple of individuals who've had this done on both sides of the brain, and it can make a big difference in the right individual. So I wanted to wrap up and just talk about some other options that are out there for just working with gait issues with people with MS. We'll talk a little bit about robotic aids, talk a little bit about newer rehab approaches and newer medications as well. So when we think about robotic aids, these are basically things like exoskeletons. What if you have enough weakness from MS or spinal cord trauma that you just cannot get out of a scooter or chair? There's several companies out there like the Cyberdyne HAL system where you're just going to say, I'm going to give you a device externally that's going to make you able to walk again. Some of the challenges with some of these devices is they have to have a motor that you wear usually as a backpack, and some of those original motor systems have been pretty heavy. Some of the original units, the backpack weighed 40 pounds. So if you were a smaller person or you had weakness or God forbid you fell down, you were like a turtle then, you're kind of stuck. This is another one, the Keeogo Exoskeleton, and then one that we're researching at Shepherd Center is the Indego Exoskeleton. And this is actually one of our Shepherd employees, a young man who had a motorcycle accident. One of the areas that we're very interested in researching in terms of another rehab option is FES Bikes, functional electrical stimulation bikes. And the idea here, and you're going to cover some of this also? Okay, I won't touch on this much. The idea here is if we can put you on an exercise bike and have electrodes that would override your weakness and let you keep going, or maybe have the motor on the bike keep moving your legs even when you're not able to get that signal from brain to spinal cord, will you get benefit from that? And what some of the studies have shown is that yes, people do. They show better endurance and better strength by working with something like the FES bike with MS. One of the slides I didn't put in here, but it speaks to your work as a cowgirl with horseback riding. So for sensory ataxia, one of the best things that we can do to work with sensory ataxia is improve your core strength. And one of the novel ways of potentially improving your core strength is through hippotherapy. Hippotherapy is physical therapy on horseback. And this was originally designed for children with cerebral palsy, but then it has branched out into adults with stroke, multiple sclerosis, spinal cord injury. Years ago, Shepherd Center had a program called Horses for Heroes. So the veterans who had spinal cord injuries through IED explosions in the Middle East, once they finished with their inpatient rehab, they would go out and work at Chastain Horse Park in Atlanta with hippotherapy. If you think about it, if you're on horseback, you've got to use all of those core muscles to keep yourself upright. And when that horse is moving, your pelvis is moving just like you're walking. If you go to a certified hippotherapists are physical therapists who have done extra training to do this modality. And if it's a certified hippotherapy facility run by physical therapists, you can get a prescription and have it covered by your insurance. And insurance will always limit on how much physical therapy you can do. And a lot of people then, if they want to keep up with it, they'll just pay out of pocket. Kind of the next level down for that would be therapeutic riding. And the therapeutic riding is usually, these are not run by physical therapists, but it can still be really beneficial. You're getting a lot of the same benefits. You just need to look at what the facility and their resources look like. If you're, say, using power mobility, you may need a lot of assistance to get on horseback. And I know if you go to somewhere like Chastain Park where the physical therapists are running, I've never seen anyone that the Chastain people cannot get on horseback. Therapeutic riding, usually they're a little bit more limited in who they can get on horseback. Yep. And then I think we're finishing up now. So one of the things that is on the horizon is the idea of surgically implantable Bions. We talked about that Bioness device to help with your foot drop. So using an electrical stimulation externally to make the nerve work again. What if we could implant the sort of a nerve stimulator surgically over the motor point of that nerve and then give you basically like something that would look like a pager, a CPU that would send the motor program that you could do one of these surgically implanted Bions over your hip flexors, over your knee flexors, over your ankle dorsiflexors, and you could say, okay, I'm walking, and this CPU would have the knowledge to say, okay, fire the muscles in this order. Now fire the other leg. There are several research groups working on this. One of the reasons we really need this is that the one muscle that we've never come up with a way of externally stimulating are the hip flexors. We do not have any Bioness type unit that can work on the hip flexors because the amount of electrical stimulus that you would need externally would probably be really unpleasant if you did that to someone. And then lastly, some research that we're finishing up at Shepherd is sort of a new use of an old drug, Amantadine. Amantadine is an old anti-influenza drug. Back in the 1960s and 70s, there was some thought that MS might be linked to influenza. It's not. When they tried out the Amantadine to treat multiple sclerosis, what they found is that about 40% of people got a nice energy boost with it. So the most common type of fatigue that we see in MS called lassitude, the non-exertional, non-heat related, someone's just unplugged your energy supply type of fatigue. Some people get a nice energy boost when they take Amantadine. Researchers in the past few years went back to the Amantadine. They said, when we look at the short-acting form of this drug and the way people with MS are using it, they're probably not getting the maximum benefit from the drug. And we think if we reformulate this into an extended release form and change the way people take it, that we might do more than just bump energy levels, that we would actually improve walking in people with MS. When they came to us with this idea years ago, and we signed on to the initial study, the pilot trial, I really didn't think that this would work. We've used Amantadine forever, and I just didn't think that it would help someone's walking. And we were wrong. In the pilot trial, it did improve walking. Now we're doing a much larger study to see if this carries over into a bigger group of people with MS. So hopefully we'll have another tool in the toolbox soon to improve walking for people with MS. Thank you very much for being here. We'll see you here this afternoon at 2 o'clock. Go have a great lunch. Oops.